No, it affected your old office, but not just.
Hi, everyone. Welcome. We're just giving it another minute before we get started, letting people into the chat.
Where?
All right, everyone, we're going to get started with this webinar.
Problem.
All right, everyone. Thank you. We're going to get started here. All right. Hello, everyone. My name is Suhini Deva, and I would like to welcome you to the Autism Intervention Research Network on Physical Health, the AIRP January 2023 webinar. Thank you all for joining us today. Because of the number of participants, your audio will be muted throughout the call. However, you can submit questions at any point during the presentation via the Q&A feature or in the chat box on your webinar console. Just a friendly reminder to please be respectful when communicating in the chat and asking questions, and note that only questions or comments pertaining to the presentation will be addressed. This entire webinar is being recorded and will be available on the AIRP website, which I will put now into the chat. You may also view the presenter slides and follow the presentation on our Google Drive archive. I have also put this in the chat. There will be a short evaluation survey at the close of the webinar. We invite you to provide feedback on this webinar and also provide suggestions for future webinars. In the interest of time, let's get started. Next slide, please. Okay. We first want to acknowledge the Health Resources and Services Administration as the funding source for the AIRP. It is my honor to introduce our presenters for today, Drs. Lindsay Shea and Dr. Lauren Bishop. Lindsay Shea directs the Policy and Analytics Center at the A.J. Drexel Autism Institute at Drexel University and co-leads the Health Services and Systems nodes of the AIRP network with Dr. Paul Shattuck. Dr. Shea leads research projects focused on improving the system of care for autistic individuals across the lifespan and utilizing population-level data sources. Lauren Bishop, an associate professor at the Sandra Rosenbaum School of Social Work and principal investigator at the Weizmann Center and the Institute for Research on Poverty and at the University of Wisconsin-Madison. Her National Institutes of Health-funded research focuses on empowering autistic adults to live long, healthy, and self-determined lives in their communities. She is currently studying disparities in health and well-being, as well as mechanisms underlying both healthy aging and early and accelerated aging in autistic adults as they age. Her social work presence experience includes roles as a school counselor and a social skills group leader for children, adolescents, and adults on the spectrum. Please join me today in welcoming Lindsay Shea and Lauren Bishop.
Thank you, Sohini. I'm excited to be here today, and I'm grateful to Dr. Bishop for being willing to co-present. This is the first Autism Intervention Research Network on Physical Health webinar that's focused on big data, One element of AIRP in our work through the Health Systems and Services node has been to launch a big data work group. And I would acknowledge my colleague Emily Hotez at UCLA for helping to form this idea and really get it off the ground. So we're here today to present to you for the first time and to help to bring approaches that are related to big data and physical health research to you. The goal of these conversations will be to support your interests and look for future research opportunities and to support collaborations. Together, Dr. Bishop and I bring a few of our own collaborations to the table for this initial presentation. From Drexel, we have the National Autism Data Center that is an initiative supported by the Autism Transitions Research Project, also funded by HRSA, the Policy Impact Project, and the Policy and Analytics Center. Dr. Bishop, would you like to acknowledge your collaborators as well?
Yeah, so I'll be talking today about a couple of our projects through Wasteman and through my team at the Wasteman Center, as well as our recently funded ACE grant, and then talking about some collaborative projects with folks across the country that use big data.
Sounds good. Here we go. So one of the first steps that the AIRP Big Data Work Group has undertaken is to generate an understanding of what do we mean when we hear the term big data. On the Interagency Autism Coordinating Committee meeting yesterday, there were many discussions of big data, and my experience has been that people interpret what big data might represent in a variety of different ways. So I'll also acknowledge my colleague, Dr. Jessica Rast, who has been spearheading this conversation within the AIRP Big Data Work Group and put together this slide summarizing some of our initial thoughts about what is big data and what does it mean for how we think about big data in autism research, specific to physical health and otherwise. So we've discussed the principles of big data being data that includes variety, so many different components within the data that you're able to use for analysis or to think about for application in research projects. And that big data also contain diverse elements. So elements that might represent where a person lives, where a person receives services, the characteristics of those individuals across a variety of socio-demographic factors, data that can be propelled into policy, and it contains measures that allow us to fill gaps that may not be available from other smaller or less diverse data sources. We've begun to identify and prioritize some values for the use of big data that we will continue to present through this big data webinar series as we refine them. So we've prioritized the uses of big data in ways that are credible, that helps us to ensure that there is completeness, accuracy, validity, and in ways that help us acknowledge limitations of data where completeness or accuracy may vary. Data that are responsive to the needs of the field, and in particular, in this case, to physical health research. That we seek to deploy big data for research that is active in avoiding ableist approaches. And we are looking for data that are significant, that are impactful, meaningful, and help us to think about system change. Transparency around both limitations as well as how we use the data, the methods that we are using to ensure the data answer research questions is also a value that we've initially prioritized. So we welcome input on this idea, and please feel free to reach out if you have thoughts or hoping to engage in this conversation. So today we're going to center our conversation on big data in the form of claims data. And so what are claims data? At the root of what claims data represent are that every time that a person has a contact with a healthcare provider or receives a service, there is a bill generated. Claims data are not, by and large, generated for research purposes, but are observations from billing systems that are used to pay for services that are received or used to document services that are received among people enrolled in certain systems. So this data that's generated from these interactions has many different elements. The individuals who are receiving the services, or patients, or participants. There are many things we know about this group. We know from these billing data if individuals are enrolled in that insurance or in that program for certain periods of time. We are able to examine information about the patient's socio-demographic and clinical characteristics, as well as, in some research studies, linkages to other individuals who might also be receiving services. How, for example, do mothers and their children who might be enrolled in the same insurance source share characteristics or be different? We are also able to look at the characteristics of the individuals who are providing the services. So when this billing information is generated, we're able to see if the service provider was, for example, based in a hospital or in an outpatient setting, if the provider was a speech therapist or perhaps ear, nose, and throat doctor. We're able to see a variety of information about the providers themselves. We can also see from this billing data a host of service characteristics. We can see the type of service that was delivered, whether that is speech therapy or a tonsillectomy. We're able to see how much of the service was delivered, whether that was 15 minutes of speech therapy or an hour. And we're able to identify how much was paid for the service and look at that variation over different patients in different places. This is teeny tiny on purpose, and that's because often when the billing data are assembled to use for research purposes, you will see a spreadsheet or many rows like this. And for example, each person will have an identifier that they are linked by way of their services over time. So if I were to have a checkup from an ear, nose, and throat doctor today, and perhaps a broken arm tomorrow, there's a common identifier for my enrollment in this system that allows us to examine people over time and look at differences in their care and what care they receive. You're seeing here a snapshot from a synthetic public use file that's produced from the Centers for Medicare and Medicaid Services that allows individuals who may be interested in using claims data to download a data set that looks very similar, if not identical, by way of the variables to the data that can otherwise be purchased from the Centers for Medicare and Medicaid Services to conduct research studies. So this is one asset for you to think about using as you're getting into explorations of using claims data for research purposes focused on physical health. Within the many rows of the spreadsheet that you saw on the previous slide, there are distinct sets of characteristics of what services were provided to whom and for what that we leverage for research purposes. So this is a resource from the Centers for Disease Control and Prevention that is focused on understanding claims data. We'll provide the link toward the end of the presentation. One element is that providers are required to assign diagnosis codes. And in many cases, there are multiple diagnosis codes assigned to a claim. So for example, an autistic individual who might be receiving speech therapy or occupational therapy would be likely to have an autism spectrum disorder diagnosis on their code as an ICD-10 diagnosis code, as well as the reason for the care that they received. So if there's apraxia or another clinical documented reason for the care, that's all captured in a distinct set of diagnosis codes that are international and are shared across providers. So they're used in consistent ways, or the codes are used in consistent ways. CPT codes, there are a few definitions around procedure codes, there are also HCPCS codes, are what service was delivered. So in this case, in the example on this slide, the procedure code 82962 is documenting that it was a blood glucose monitoring device, or in the second example, an intranasal flu vaccine administered during the visit. And this is used because it defines reimbursement in the billing system, but it also allows us as researchers to look at what services the person received. So when we put these elements of the data together, we're able to, on the far end, under the general category box, get a sense of what types of clinical concerns individuals are presenting with or assessed for, and what types of care, so we can more broadly group things like flu vaccines into preventative care categories. Provides us a lot of granularity and options for how we can group these data elements together. There are many sources of claims data that are available, some for purchase, some for free, and some through other specific data use arrangements. Public health insurance, the two systems available in the United States, Medicaid and Medicare, are available through the Centers for Medicare and Medicaid Services for purchase to use for research studies. There are private health insurance, which is typically associated with employment, and there are often pooled insurer sources. So for example, MarketScan or Optum Health are data sets where they take multiple private insurers and put them all in one place so that people can use them for research purposes with broader groups of people who have that private insurance. There are also all payer claims databases. These are unique data sets that are culled across multiple insurers, so private health insurance and public health insurance. Some states, most states have all payer claims databases for their states, although the requirements established through legislation for the contributions to those APCDs within states is highly variable. There are also national all-payer claims databases that capture focused types of visits, like emergency department visits or the NEDs, inpatient stays or the NIST or the NIS, depending on how you use it, or readmissions to hospitals or the NERD. These data are all available for smaller fees from HCUP. We're learning more since the implementation of the Affordable Care Act about how to access the health insurance exchanges. So this is a subset of insurance for people who are not on Medicaid, but also may not have private health insurance. So it's yet another way that we structure our insurance options in the United States that we can think about by way of an option for claims data research. There are other government systems that produce claims data or data that closely resemble claims data because they are tracked for enrollment or reimbursement for services. So systems like the Vocational Rehabilitation System, which is centered on employment preparation services and job finding, Social Security Administration, Veterans Administration, and other insurers such as TRICARE. So when we think about autism and physical health research questions using claims data, how do we ensure that we are examining autistic individuals? How do we look for autism in claims data? And if we go back to the CDC's resource on how to understand and work with claims data, we can think about these elements of the ICD-10 codes or the diagnoses and the service codes to help us consider what our approaches might look like for identifying autism in claims data. When we look at the diagnosis codes specifically, there is a resource from the Centers for Medicare and Medicaid Services called the Chronic Conditions Warehouse, which produces validated algorithms for the identification of multiple conditions. Chronic conditions are prioritized. Autism spectrum disorder does have an entry, a validated algorithm in the Chronic Condition Warehouse that sets the criteria that we can use within claims data to ensure that we are identifying autistic individuals. In this case, autism spectrum disorder is defined as one inpatient or two outpatient diagnoses on a claim. It also provides this validated algorithm, the diagnosis codes that you can use to search. And here we see both the ICD-10 and the ICD-9 diagnosis code, which is particularly helpful as we think about longitudinal analyses as these diagnosis codes have changed. There have been 6 studies that have been published that have examined autism on a claim and looked at clinical records or done evaluations of individuals to identify how well claims data actually are true to the community of autistic individuals. This study looked at records and had clinical experts examine individuals who had an autism claim and compared it to that expert evaluation of an autism diagnosis and found a positive predictive value, or the ability to see true autism cases, approaching 90% in the claims data when the one inpatient, two outpatient requirement was applied. In the field of autism and physical health research, especially, we can think of many ways that we could potentially use claims data to examine healthcare experiences, physical health conditions, and other elements of healthcare for research studies. We don't have to start completely from scratch. There are a variety of ways that claims data have been utilized in other areas to forward how we can understand and improve the system of care that supports autistic individuals, and in particular, their physical health care. Increasingly, claims data have been used for predictive analytics. Machine learning methods have been applied using algorithms, and in this case, to the opioid overdose identification in claims data to understand potential prevention routes in individuals who have experienced an overdose. Longitudinal analyses, because these data do follow individuals over potentially very long periods of time, are possible for looking at studies of follow-up, in this case, 18 years of follow-up of Medicare beneficiaries, and looking at different diagnoses such as dementia, as well as disparities, racial and ethnic disparities, which are key in particular for Medicaid and Medicare, where there are particularly diverse groups served. Claims data, because they include the amount paid for services, are also a wonderful tool for thinking about potential cost effectiveness and financial outcome analyses. How do services make a difference in outcomes across individuals who may present with different types of diagnoses? With that, I'll hand it over to Dr. Bishop for further perspective.
Thank you so much, Dr. Shea. So what I'm going to do here is I'm going to go into sort of more depth about how we've applied some of this in practice within the research that we've done in my lab, and then in also some collaborative projects across different labs throughout the country. So I want to first point out that when we use big data for research, we're typically studying people on the autism spectrum as a group or an entire population. So because of this, the findings in a study may not be, and certainly are not true for everybody who's encapsulated in the population. However, when we're looking at this, we're often looking to see whether there's a higher probability or risk of a certain physical health problem or set of physical health problems or mental health problems based on being in one group compared to another group. So it could be that we're looking at autistic adults compared to non-autistic adults. It could be that we're looking at autistic adults with intellectual disabilities compared to autistic adults without intellectual disabilities. And we can also do comparisons across diagnostic groups that are identified using ICD-9 or 10 codes, either within their claims or within the eligibility files attached to the claims. Next slide. So, some of the major benefits of using claims data to investigate physical and mental health in autistic people are that, first of all, we have much larger sample sizes using these data than we would sample sizes that are collected prospectively from autistic people within clinical settings. And also because we know that there are certainly lots of biases that are associated with folks who are able to go into clinics or able to participate in research studies. In claims data, we're going to see participants and beneficiaries who are more racially diverse and ethnically diverse, as well as more socioeconomically diverse. I think really important in this arena is that data from claims represent autistic people who utilize services, and they utilize systems. And because of this, we see policy and service system implications that come from these data that we wouldn't be able to find within prospectively collected data. It tells you about the reality of what's going on within a population of people, and it's an entire population of people in many cases and not a subset. There are some data sets where you're getting a subset of folks who are in the entire population, but for the most part, administrative data and claims data represent the entire population that is using that service or who benefits from that service system. I think that another emphasis when we think about this from an applied perspective is that these types of studies allow us the opportunity to build partnerships with county, state, and federal agencies and partners, and to answer questions that are important to them and that are meaningful to them as they're planning for their services. And, when our agency partners are able to, look at our research findings, they can see very direct implications for the work that they do in practice. And, because of this, there are very clear policy implications of the findings. And it, can do things to emphasize maintaining funding for programs, adding additional funding, altering the way that claims are reimbursed for certain populations like autistic adults. Perhaps with this research, as we move forward, we'll see changes in the way that Medicare or Medicaid reimburses for primary care for autistic adults, as well as, potentially other benefits long-term that could truly benefit people at the systems level. And create ways in which we can help support health equity and help support equity in services by increasing resources for populations in need. So to access the claims data. So, Dr. Shea did a really wonderful job of talking about data sets where you can purchase data from federal agencies. However, there are other types of administrative data that can be obtained from states and counties, and typically those data require you to build relationships with the entities in order to access their data. As an example, we're in the process of negotiating a data use agreement to access our long-term support services data that we would then be able to link to Medicaid data to look at the effectiveness of home and community-based services waiver programs in Wisconsin. And doing that wouldn't be possible without the relationship that I've built over time with the Wisconsin Department of Health Services, where they know that we're accessing data in a way that's responsible, in a way that meets their program needs in addition to contributing to research. I think that in a lot of cases, it's really important to choose the right program for the research questions at hand. So if you're looking at health in older autistic adults, most older autistic adults will have Medicare. If you're interested in end-stage renal disease, so kidney disease, everybody with end-stage renal disease has access to Medicare because of that diagnosis, so you can do population-based studies using Medicare. If you're looking at health in younger adults, you'd be using Medicaid data. And choosing the right program either at the state or the national level is important in terms of your ability to answer questions. So for state data, the main benefit of accessing state data as opposed to national data is our ability to link to eligibility files and to other service system level factors. National data can tell us more about the full population of autistic adults and their physical and mental health problems. I think that something that is also really important is having the computing infrastructure. So these data are, in many cases, very computationally intensive and take a fair amount of server space and computing infrastructure to analyze, especially if you're doing methods such as machine learning methods. And it's also important to have the computing infrastructure in place to be able to provide the correct protections for these data. Many of these data are restricted data with identifiable information, and you need to have the safeguards in place to be able to access those information safely. As Dr. Shea discussed, we identify autistic people using ICD-9 and 10 codes. Typically we'll look at one inpatient stay or one code within an inpatient stay or two within an outpatient stay. We can also use with state data eligibility files to be able to identify diagnoses. So in some of our studies, we're looking at both ICD-9 and 10 codes in addition to eligibility files to determine who qualifies as having an autism spectrum disorder diagnosis. And then we're using established algorithms that will help us extract types of conditions using ICD-9 or 10 codes. So the chronic condition warehouse is one option. There also, for specific diagnoses, dementia is a good example, research-based conventions for extracting these data from claims data or electronic health records data. I want to talk a little bit about the potential for linkages across administrative data. So in terms of individual level data, so when a Medicaid beneficiary who qualifies for Medicaid through the SSI disability pathway enters into Medicaid, they go through the process of filling out a functional screener to assess their living situation, activities of daily living, instrumental activities of daily living, support needs, diagnoses, health service needs, et cetera. And this is used to help folks qualify for the program. These data are available to link to Medicaid at the individual level so that we can see something about folks' needs in terms of services and supports. We're also able here at the University of Wisconsin through the Institute for Research on Poverty to link Medicaid data to social service data more broadly through the Wisconsin Administrative Data Core. And I have an icon here that shows the data that we're able to harmonize across these programs using both unique identifiers that carry across these systems, as well as probabilistic matching to match records to each other. And here we're able to link data on Medicaid to work data, education data, homelessness services data, et cetera. So, as we, as a field, become more sophisticated in our ability to utilize and analyze administrative and claims data, we'll be able to do more and more to link data across systems and give us a really holistic picture of service needs and support needs and the effect that these services and supports might have on physical and mental health for autistic people. Next slide. So we can also link administrative data to contextual data. So if we have zip code data, we can do things like link those zip code data to block group or neighborhood level characteristics through the American Community Survey, which is a federally collected data set that includes a lot of contextual data about local geography and local needs. There are, at several universities throughout the country, there are 33 federal statistical research data centers that collects federal microdata from the Census Bureau and can be linked to other administrative data sources. The process for becoming part of one of these centers is intensive, and you have to go through a lot of trainings to be able to access data through the RDCs, but this is something that really hasn't been utilized in autism research to date, and I think provides a lot of opportunities for folks to start innovating the use of administrative data and claims data to study physical health in autistic people, as well as the contextual factors that may be associated with physical and mental health. We can also we can include data on neighborhood level socioeconomic status if we have 9-digit zip codes. We can look at historical data and policy relevant data. So for instance, in the field of sociology over the past couple of years, there have been some folks who are studying health outcomes in people who live in states that were part of the Confederacy and are looking at the proportion of slaves in a county historically compared to the population of slave owners. And these studies are finding that in counties where there are historically a large proportion of enslaved people, that white people's physical health today is better as a result of this historic level of segregation. And this kind of thing could be applied to autism services and physical health in autistic people. We can also create data sets that are linked to county and city and block group level characteristics to look at service availability. So, we can do a survey of the service providers within a state and identify which areas have higher levels of service availability. And I'll show an example of one of the ways that we've done this in the past. And then we can also link to data on hospital and provider level characteristics to see if there's something about certain hospitals, like maybe the fact that it's an academic medical center, or the fact that there is an autism specialty treatment center, and see if these hospital characteristics or provider characteristics may be linked to better quality care over time. So I'll give a couple of examples of things that we've done with the data that we've used within the groups that I work with. So in this paper, we looked at patterns of enrollments in Wisconsin Medicaid in autistic adults to see whether there is an increasing proportion of autistic people within the Medicaid system as a way to prepare states to serve the needs of an increased population of autistic Medicaid beneficiaries. So, and we found that there is a really dramatic increasing proportion of autistic adults without intellectual disability who are Medicaid beneficiaries within the state of Wisconsin. However, there are relatively stable populations of adults with intellectual disability. And, I think that this has some major implications for the service system, and that the Medicaid system is going to increasingly be serving autistic adults without intellectual disability, in addition to adults with intellectual disability only, adults with Down syndrome, and autistic adults with intellectual disability. So here's an example of a paper that was recently published out of my collaborator, Brittany Hand's lab, where we looked at mortality in autistic adult Medicare enrollees over age 65. And in this study, we found that autistic adults had a 2.87 times higher mortality rate compared to non-autistic adults, and that on average, autistic people died at a median age of 72, whereas non-autistic people died at a median age of 75. And we saw an increased mortality rate for males and an increased mortality rate for autistic people with intellectual disability. I think something that's interesting about this study is that we've done some other studies looking at mortality and age of death in a broader age range of autistic people. But what these data seem to be showing us is that once autistic people hit age 65, if they live to age 65, they're much more likely to live a comparable lifespan to non-autistic people, which I think has implications for actuarial science and to service provision within the field. Next slide. So this study is another study that utilized Wisconsin Medicaid data. And here we found that physical and mental health problems were highly prevalent in autistic people, regardless of whether or not they had intellectual disability. So as an example, about half of the autistic adults who are aged 40 and older in the Wisconsin Medicaid system have cardiovascular disease. About 85% had a sleep disorder, about 70% had psychiatric disorders, and about 55% had neurologic conditions. So interestingly, we did see an increased rate of some conditions in autistic adults with intellectual disability compared to autistic adults without intellectual disability. And it was likewise true for autistic adults in the other way. So, in this photo here, the screenshot that I've included, you see that depression rates were higher in autistic adults who did not have an intellectual disability, as were rates of anxiety. And then epilepsy was more prevalent in autistic adults with an intellectual disability. Next slide. So this study is not focused on physical health, and it does not use claims data, but I'm including this as an example because it's an example of the way that you can use geographic data that could then be linked to claims data. So in this study, we looked at the autism spectrum disorder providers in Michigan and then geocoded the location of these providers and used network analysis to assess autism spectrum disorder service availability in relation to population distribution, socioeconomic disadvantage, urbanicity, and immobility. And in this study, we found that that people who live in rural neighborhoods had fewer available autism spectrum disorder providers compared to individuals who live in suburban and urban neighborhoods. And then in addition, neighborhoods with greater socioeconomic status disadvantage had fewer autism spectrum disorder providers available. And we also found statistically significant spatial disparities, where wealthier suburbs had good provider availability and fewer providers were available in poorer and urban neighborhoods. So with this, if you wanted to link these geographic data to claims data, you would be able to see whether availability of autism service providers was linked to physical and mental health problems in autistic people by linking the service provider data to the zip code data at the individual level within a claims data set.
Thank you, Dr. Bishop. That's, I think an incredible array of opportunities for where claims data and the linkage to other administrative data sources can take us for physical health research specific to autism. So our goal today was to put forward that claims data are a resource and that we can think about claims data in terms of our research questions that we're prioritizing and pursuing. There is absolutely a set of limitations associated with using claims data. To build upon Dr. Bishop's list, which really was thorough, these data are not gathered for research purposes. So there is often a data cleaning step that must be undertaken around missingness and steps that must be examined as well on variation in data quality. There are ways that we are particularly limited in data sets like claims data around, for example, differences in gender identity, because the billing system has not caught up to where we are by way of understanding differences beyond binary identity for gender. We know that data about service need or the experience was that speech therapy visit for person A versus person B of equitable quality, or were there big differences, pointing back to Dr. Bishop's study related to geographic differences in provider availability and potentially quality. We also know that claims data, because they're generated from services that are used, lag behind where we are real time. We're just now starting to get some of the 2020 COVID data that really prevents us from real time being able to use these large data sources to answer pressing public health questions. And so that is a fundamental issue. There are also ways that some of these data sources can be very costly. to accrue, to keep over time, and to think about using by way of the infrastructure that Dr. Bishop mentioned, as well as the data analytic experts who are able to wrangle these very large data sources and put them together for utility, for research purposes. And I've included here a note just about differences across the claims data research sources in terms of, in particular, race and ethnicity variables and how these variables are not consistent. Sometimes even within data sources, the quality and nature of these data are changing. And so that is an important limitation as we think about health equity and how we consider our structure for analyses to be thoughtful of where these data may be well poised versus where we need to be careful about both our analytic strategy and our interpretation of the data that we produce. Thank you so much for being here today. We have a few slides for the ARP folks to wrap it up. I believe that these resources will also be pasted into the chat for you. There are a few elements here that you can explore by way of simulated data sets, as well as other links that give you sample code and opportunities to think about what is or is not inside claims data sources, as well as getting claims data actually in hand. Thank you, and thank you, Dr. Bishop. This has been really exciting to launch this webinar with you. I look forward to questions.
Thank you so much, Dr. Shea and Dr. Bishop, for your presentation and your work in this area. We now have time for questions and answers from the audience. I will start with questions already submitted, but feel free to enter any additional questions. As we give the attendees a chance to think about some questions, we want to invite you to register and attend our February webinar, which will be presented by the Autism Society of America's Vaccine Education Initiative. You can register for the upcoming ARP webinar here. I will put it right here in the chat. All right. And next you can follow us on social media. Here are links to our social media channels. And we're going to go ahead and go through the Q&A questions to see if anyone has any. If not, I can jump the line because I definitely have one or two. All right. So, Doctors Shea and Dr. Bishop, I do have a question, and that is, what tips do you have for finding claims data researchers at home institutions, or kind of like what the process of data use agreements or ways of sharing that might be a little bit easier?
Or let's go first.
Yeah, I can go first. I think that, so the reality is that as a field, we are really far behind other fields in terms of our ability to leverage large data and claims data sets. So I think that this is an area that's really ripe for interdisciplinary collaboration. So schools of medicine, public health are great examples. There at many universities, there are institutes on campuses that have access to high quality administrative and claims data. So here at Wisconsin, our Institute for Research on Poverty is where all of our on-campus data sets are housed. And we also house Social Security data at the Center for Financial Security, and then some health data on the Center for the Demography of Health and Aging. So networking with folks at these different entities is really helpful. I've also found that economists and data scientists and computer science people at universities are often looking for collaborators who have clinical questions and who have clinical experience and would like to investigate questions that have policy relevance or individual relevance for certain groups. So finding people who have the data science skills and the data science methods knowledge to be able to start working on these projects collaboratively is one of the really helpful and fruitful ways to go.
Yeah, I think, those are all the best suggestions. The other opportunity is sometimes you can uncover collaborators who you may not have known existed, even by looking at published research across your institution, just getting into PubMed and doing some searches for people who are based where you are. And this really helps, for example, in the use of the national Medicaid and Medicare claims. There are large fees to be able to purchase the data, but within your home institution, you're able to share those data for a one-time $2,000 fee. So it becomes far more affordable when there are multiple researchers engaging in this process together, as well as the learning opportunities from each other and sharing infrastructure too.
Thank you for that answer. We do have a question in the chat, and that is, as the definition of ASD has changed over time, it is very common for us to see middle-aged and older adults with intellectual disability diagnoses, who, given current definitions of mild ASD, warrant and as ASD diagnosis as well. This large population of individuals with ID will not be captured if an ASD code F84 is the entry point to the search. And someone in the chat is wondering, how would you best address this?
That's an excellent question.
It's a great question.
And I think will be an ongoing element for us to tackle in the science of using claims data for these sources. It's always something we need to acknowledge by way of the newness of our understanding of autism in adulthood, and that there are elements of that that have translated to these insurance programs, how services are billed. If there are not programs for autistic adults, there are few incentives for providers to code autism on a claim. And so there are ways that you can conduct sensitivity analyses to look across individuals over time in terms of diagnostic switching. There are ways that you can look at variation. There have been several adult autism specific programs in Medicaid for over a decade now. And so you can look in places where there have been, as to Dr. Bishop's point, enrollment criteria, where there have been sort of eyes on the person to examine or verify an autism diagnosis. So there are some strategies, although they're all imperfect. And there are ways that the changes in these diagnostic criteria will continue to be an issue in how we think about our research questions. Dr. Bishop, I don't know if you'd add anything.
Yeah, I think the thing that's really important to think about when you're contextualizing this research is that it represents a service system as it is, right? So when you do a study of Medicaid beneficiaries or Medicare beneficiaries, you can get some information that might give you, a clue about what's going on with autistic adults as a whole. But however, these studies are frankly just representative of the beneficiaries within the service system. So I think that, like in all research, it's really important to use different methods to study physical health in autism. So we've at this point done a fairly large amount of claims-based studies of physical health. I think there's still a lot more work to do. But it's important now to also go in and collect prospective data from autistic adults to look at how physical health changes over time, and to link that to at the individual level to Medicaid records and to electronic health records to see whether it's showing up in claims. And this is something we'll be doing with our ACE, is linking individual prospectively collected data to claims data. And studying this at the individual level so that we can get a more nuanced picture of it. But, any service system reflects changes within the population. So Medicare right now, the autistic adults who are identifiable in Medicare right now are not going to be the same as the autistic adults who were identifiable in Medicare in 30 years, assuming Medicare is still around in 30 years.
And some of the work that Dr. Bishop presented by way of how patterns in enrollment are changing, they present important baselines. We've reported in some of our work on the Medicaid side nationally on uptick in numbers of autistic individuals. I think that work is a primary stepping stone to understanding how this is changing so that we can attempt to quantify and perhaps even maybe Dr. Bishop, this is one of our next endeavors, to look at the differences between new people who had ID and are moving into an autism diagnosis versus those who always had one, and what are some of the differences in their characteristics. So
Yes.
it's a great question.
Yeah, we should actually do that. We should. Yeah, I feel like this is one of the other papers we need to work on.
Yep. Come join us, everyone. Come join us.
Because there's a lot of work to do here and we need people to join us.
I'm sure. Yeah. So the next person actually had two questions. Now the first question is going to be, could you comment on the role of artificial intelligence to extract complex patterns of health from large claims data sets?
Yeah, so we do a fair amount of ML work in the collaborations that I'm working on, and so ML is really cool because it can identify patterns that you wouldn't be able to identify with standard statistical techniques. The issue is that it's a black box, right? So you don't know exactly how all of the inputs are going into these models and exactly what they mean. So, it's essentially identifying latent variables that are completely unknowable. And we don't know yet where this will lead. And, beyond this, once you've extracted these patterns of health using AI, how do they apply to actual clinical practice and clinical presentation within autistic adults who have these patterns? So I think this is a big next step for research that we're certainly working on right now. But, I think it's important and useful because you can do things like create algorithms to flag people in electronic health records as potentially at risk for falls, as an example, which could have some real clinical benefit and utility.
Second to all of that.
Thanks. Okay. And then the follow-up second question was, are there concerns that this research could be misused by insurance companies to identify costly services and deny claims?
Yes. Yes. I'll say I have a big concern with this research about actuarial science and life insurance companies, and potentially using our research to deny life insurance to autistic adults, especially if, because I think that our sense of average age of death in autistic people is probably skewed a bit younger than it is in practice just because of changing cohort differences. So if it isn't this 20 to 30 year gap in life expectancy, this is something that, life insurance companies could be using to deny coverage to people, which, I think is a major concern if, as an example, there is an autistic adult who has a baby and wants to get life insurance to protect their family in case they die and can no longer contribute financially to the family. I see this as a big potential issue in the future. Okay, Lindsay, I don't know what your thoughts are about misuse of this information by insurance companies.
Yeah, I think, the majority of my research is rooted in Medicaid, and there are some peripheral or spillover effects into private insurance that are important to understand. I think there are ways that we know that Medicare data, because there are profits to be made in the Medicare sector, perhaps in a way that is less possible in Medicaid. And there are already some safeguards in ways that data use agreements and the way that they're evaluated by the privacy boards that govern them seek to have cautions around that work. But it still, I think it falls upon the researcher to formulate questions in exactly the way that Lauren just put forward. What does this mean for the science behind how people live their lives and what this, how this is going to impact policy broadly. And that requires collaboration too, so that, you can have that sort of thoughtfulness and multi-system understanding of what your results mean. I think it's a very important question.
Yeah, and
Absolutely.
And, frankly, it's not always responsible to publish every analysis that you run, right? Because sometimes there are massive potential unintended consequences behind a finding that, if you publish it, it may not be good for society as a whole. So, I think that having enough reflection and big enough teams that you're careful about this and careful about how you use the data and how you report findings, I think is really, really important, especially when you have access to large data sets and can, if you really wanted to, churn out a lot of analyses very quickly.
Thank you. So we are just after 2 p.m. So we are going to begin wrapping up here. Thank you again, Dr. Bishop, as well as Dr. Shea. Thank you again for everyone for attending this webinar. The webinar has been recorded and will be archived on our AIRP website and on our YouTube channel. Please take a few moments to complete our survey to provide your feedback for future webinars. That link is now in the chat. And yeah, I hope you guys have a wonderful rest of your day. Thank you so much for this knowledge, and we will all see you next time.
Thank you.
Thank you.
Thank you, everyone.